Hello and welcome to our next episode of After the Visit Ends. Today we are joined by Dr. Dupuis, and I am so excited to talk to her today. Dr. Dupuis, thank you so much for being here.
Thanks for having me, Neerja. I'm really excited to chat with you.
So, we would love to start off by hearing a little bit about yourself and your journey in oncology.
Yeah. So I'm originally from upstate New York, and when I was a kid, I thought I was going to be a lab-based scientist. This was the goal. This was everything I did in high school was with the goal of being a lab-based scientist. And then when I was a junior in college, so my mother has multiple sclerosis, and she was having a particularly bad flare. I spent a lot of time with her at physician's appointments, and I really loved the sort of human way her physician kind of set all of the pathology and physiology to the side and sort of talked
Yeah.
to my mom like a person, like a human. And I really resonated with that. I loved that. And so I must have been a sophomore because I think I decided, okay, I'm going to look into whether I could be an MD instead or in addition to, and I discovered these MD PhD programs. And so part of being successful sometimes is not knowing that things shouldn't work out for you, right? Like it seems like a crazy thing to just all of a sudden halfway through your sophomore year decide, okay, I'm gonna go be an MD PhD instead. But that's what I decided to do, and I was fortunate enough that my grades and my classes were in a place where it was easy to sort of integrate that goal into the plan. And so I ultimately applied to and got into some MD PhD programs. I stayed at my home program in Buffalo, New York, where I got my MD. And then serendipitously, I was supposed to be in an infectious disease lab for my PhD. And that PI needed to return home suddenly to his home country.
Mm.
And so I was left without a lab. And so I was scrambling last minute. And I rotated in the lab of my PI, Kelvin Lee. He's now the head of the cancer center at Indiana University. But at the time, he was at Roswell Park. He was the head of the Department of Immunology. And he was a multiple myeloma MD. And so I loved him and I loved the lab. And so I pivoted and I joined an oncology lab. And one of the cool things about being an MD PhD with a PI that's a physician is
Mhm.
that I got to go with him every Thursday afternoon to his myeloma clinic. And I have to be honest, I liked the science, but it didn't spark joy the way that being in his clinic sparked joy. And so it became pretty clear that I wanted to build these longitudinal relationships with patients. I wanted to walk with them on this pretty awful journey, right? This awful kind of health journey. I wanted to be with them in the way that my PI showed up for them. That he was curious about who they were as people. He knew the names of their kids and pets. He felt very personally connected to them, and I wanted to be that. And so after I went back to finish my last 2 years of medical school, I had applied to physician scientist training programs, but I was already starting to, in my brain, pivot away from a lab-based career and think instead about what it could look like to have a medical educator and clinical educator career. And so um, ultimately, I, through my training, sort of refocused my passions into medical education and patient care. And I was lucky enough to do my residency training at Duke, and I had a program director that supported me de-enrolling from a physician scientist program and instead focusing on a categorical internal medicine career and a career focused on medical education. And then I went to a fellowship that similarly supported me in that effort. And my fellowship is really where I became an oncologist. So my fellowship was at MD Anderson, which is, big, huge, very well-known cancer center, arguably number one cancer center in the country. But my clinic was at the local sort of catchment community hospital, taking care of patients who lived in the general Houston community, and that was where I became an oncologist. And so it started with being inspired by my mom's neurologist, my PI during my PhD years, who was an oncologist, and then seeing a number of physicians and oncologists throughout my training journey that taught me the kind of physician that I wanted to be. And then I was lucky enough to end up here at Vanderbilt, where I've been an oncologist for the last 5 years. And it has been the most rewarding journey of my life, for sure.
What an amazing career. And I love that you emphasize that nothing is straightforward. And I think that there needs to be more discussion about how very oftentimes we can take a step back and understand whether the direction we're going in is actually truly what we want the direction to be. And I appreciate you kind of sharing the reflections you had along the way. And I mean,
Yeah.
it sounds like oncology very early on felt like your place in medicine, but you had to make the effort and make the steps to really solidify that and clarify that within your mind. So,
Yeah. And it's not linear. You're right. And
yeah.
it's not lost on me that you and I are reflecting this on match week,
Yes.
where medical students are finding out yesterday, hopefully that they matched, if they matched, and then we'll find out later this week where they matched. And I think that a lot of us think that we can sort of plan for every step of this journey and every step of the way. And I think if I've learned anything, it's that a lot of things are out of our control, whether that's personal circumstances, health circumstances, relationships,
Yeah.
children, but things that like we can't really have any control in, you have to reframe. And I think so many of us in medicine are taught, well, I'm going to do 4 years of undergrad and then 4 years
Yes.
of medical school and then 3 years
Right.
of residency and then 3 years of fellowship. And then I will be where I need to be. And then my life can begin. And then
Yeah.
everything will have worked out. And the truth of it is, and it's trite and it's silly because I know people say it all the time, but like life is what is happening to us while we are making those plans, right? So, it's okay to listen to those voices in your head saying maybe there's something else out there that's going to bring me joy.
Definitely. And Dr. Dupuis, you've built this remarkable career as an oncologist, but what makes your story especially compelling to me is that you've also invested very deeply in narrative medicine and humanism in medical education.
Yeah.
So I'd love to talk about that side of your work. Where did that interest begin, and why has it mattered to you so much?
Yeah. Yeah, I'm old enough now that when I was in medical training, medicine, the medical humanities, even things that feel very like obvious now in medical training, like patient-centered communication, medical ethics, these were things that were not heavily focused on when I started medical school. So again, MD,
Mm.
PhD, I started medical school in 2007, so 20 years ago. And these were not things that were really, I think a lot of time was not spent on those topics. And so when I got to my intern year at Duke, I had always been a personal writer, kept a journal, did a lot of reading. But in intern year, I found, as many people do find, I found myself feeling very burnt out, very sort of dissociated and disconnected from the thing that actually brought me into medicine, which was the patients. I'm sure I'm going to say something that other people have probably thought, maybe not voiced out loud in so much detail, but when you're on your fifth admission of the night and you're getting crushed from the ER and you're cross covering and patients are sick and you're at the end of your rope, it's very easy to forget that there are humans on the other end of your notes and your orders. And an admission from the ER is no longer, a three-dimensional human being that is coming and suffering. It is just one more task that needs to be completed so I can sign out and go home and go to sleep. And I
Yeah.
remember hating that feeling. That felt horrible, right? Like that's antithetical to why we go into medicine. And so at Duke during my intern year, some of my much smarter upper level residents had started a workshop in narrative medicine, and they
Mm.
invited down a guest speaker to coordinate that workshop for the weekend. And that workshop, I think, changed the trajectory of my career. And so they asked us to submit a piece of writing to apply, and it was, and you'll know this, Nirjet, like a protected 3-day weekend to participate in this workshop. Friday, Saturday, Sunday, that's all we were doing. And we were given the time off
Unheard
to do
of.
it. Unheard
Amazing.
of. And it was with colleagues across the spectrum of medicine all year, med peds, med psych, and internal medicine, and just coming together to talk about these pieces of writing that really meant something to us. And we had all written about a patient case, something that had really resonated with us. And just being given that time to reflect on what that patient must have been going through, what I was going through, and to really stop navel gazing and to start thinking about what it means to be in this really beautiful communion with people who are sick and vulnerable really resurrected for me that feeling of humanism in medicine, the idea, and it should not be controversial, but that patients come to us with a full life that they've led, a life full of experience and talents and hopes and fears and pain and family and jobs and influence. And they come to us with their illness and they bring it to us and they say, here's my story, help me make sense of it, and hopefully help me alleviate suffering. And we come with all of the things we've experienced and also a body of knowledge And we meet somewhere in the middle. And the idea is that we really co-create that story going forward together. You bring me the details of your history and everything that you're feeling. And I hopefully bring the thoughtfulness, the openness, the receptivity to that story to interpret it, filter it, and then come up with a differential diagnosis and a plan that I hope relieves that suffering in some way and gets you some understanding of what's happening to yourself. So getting that experience at Duke inspired me to create a narrative program there that is still ongoing with their internal medicine program. It is helmed by our palliative care colleagues, who I think are the perfect people in a lot of ways to run this type of work, where it is part writing, part thinking about patients, but a big part reflection and sort of group understanding of what we're going through. I carried that same work forward to MD Anderson when I was there as a fellow. COVID really, I think, unfortunately, was probably the time where we needed it the most, but the wheels really kind of came off the wagon during COVID with that work. And so when I came to Vanderbilt as a faculty member, I looked around and said, do we have anything like this that's happening right now? And I asked some colleagues that I'd met, and they said, no, but you need to meet this guy, Chase Weber. And so Chase, he's my partner in crime. I met him, luckily enough, my first year of faculty. He'd been here a couple of years. He's a hospitalist. And he put together a whole curriculum for narrative medicine and the medical humanities at Vanderbilt, and just needed somebody else to partner with him to get it off the ground and get it going. And so Chase, Michelle Ismailov, who is a physician writer here at Vanderbilt, they had already put together this beautiful curriculum. And I just kind of brought some of that young, naive enthusiasm to the role, and we were able to get it off the ground and get it going. And so we've had a GME certificate program in narrative medicine and the medical humanities that's been running now 5 years at Vanderbilt. And we have had 25 or 30 independent publications come out of that program that trainees have felt empowered to write about, with, and for patients, and to really digest the experience of what it means to be a human taking care of other humans.
The fact that you consistently saw this gap in medical training and created programs that these gaps were meant to fix is such an amazing and productive approach to, as you said, developing a safe environment where trainees feel comfortable being vulnerable and sharing their thoughts and their feelings. And Dr. Dupuis, over the years, my question is, what are some of the specific skills that you've noticed that narrative medicine can build in an oncologist? Is it better listening? Is it emotional regulation? Is it language choice? What do you think it
Yes.
is?
Yes, it is all of those things. I think just for the listenership, ostensibly many people know already what narrative medicine is, because they've been through trainings in their own medical or maybe even undergrad or medical school curricula. But for folks who don't know, this is a discipline, it's a skill set. It was really developed by Dr. Rita Sharon at Columbia University and a number of thought leaders at Columbia and other places, Yale, and has really grown outward to be this rigorous national movement. It's an academic movement. I would say it is not just a way to sort of self-reflect and think about kind of your role in medicine, but it really is it's an academic discipline. It is centered around this idea of active listening, right? So listening very actively to the things that people are saying and absorbing it, interpreting it, and acting upon it. And so it is giving the respect to the patient that their story is their own. And my job is not to manipulate that story. My job is not to twist that story, but my job is, as best I can, absorb the fullness of that story, hear what is both said and what is unsaid, to try to peel back the layers to understand the thickness of the narrative that that patient is giving me, to better interpret the medical side of that story. And so what do I mean by that? It might be identifying the key details of how that patient is presenting in a room. And so you mentioned that story, Tamales, that I wrote about and published earlier this year. One of the things I noted was that my patient, who I dubbed Christina for the story, usually came in very nicely dressed, but when she would wear pajamas, it was a sign to me that she was not doing well, that her cancer was probably progressing, right? That is an unspoken detail. She never acknowledged it. I never said it out loud, oh, you're in pajamas. And yet, if you're paying attention, I know that every oncologist or future oncologist listening to this story has all of those little tells, right? So you're paying attention to the details. You're hearing the narration of the story. So who is telling the story? Does the patient usually tell the story, but this time it's their spouse or their child who's coming with them, right? That makes a difference. You're paying attention to where the story goes, right? So how does it move? You know, how many times, Nirja, have you been called down to the ER to admit a patient, and maybe the chief complaint is chest pain, and you say to the patient, well, tell me how it all began, and they say, well, in 1972 I broke my ankle, and you're already rolling your eyes because you're like, bro, I don't have time for this. You know, I've got two other admissions waiting, I'm getting
Yes.
paged out the backside, I need you to just tell me about your chest pain. Is it typical or atypical, right? Like, this is what we're
Hmm.
trying to get to. And yet, if you let the patient give you that journey,
Hmm.
that detail of their 1970s medical history onwards may make a difference in why they're starting there. And so it is therapeutic to allow the patient to unravel the story in the way they wish to unravel the story. And so that is a very basic overview of what narrative medicine is, and that doesn't even get into any of the aspects of social justice, cultural awareness that are deeply embedded in what narrative medicine is and cannot be divorced from narrative medicine. You cannot receive a story without understanding the biases and the injustices that are happening to marginalized communities, because those are often, not always, but often the patients that we are admitting, receiving, taking care of. So understanding that's deeply important. And then thinking about how do we then apply that as trainees, as learners? What does it mean to collect that story? One of my favorite stories is of a resident who was with me on the oncology and patient service. He's med peds. He went on to do my narrative medicine program, but had not done it yet. So this was just instinctually who he was. We had a patient who came in, was in terrible pain crisis, could not even really talk to us. And we get the pain under better control and we start chatting. And this patient blooms like a flower and tells us his story, that he is a musician and that we can find the music that he's been a part of on Spotify. And this is not uncommon in
Wow.
Nashville, actually. You know, Nashville, it's the home of musicians. And so my resident, of course, again, busy admitting day, he goes, well, okay, let me find you on Spotify. What song should we listen to? Pulls the song up and we listen to it in the room. And this patient, you could just see how delighted he was that his doctor took the time to hear a song that he had created. And later I call this resident to run the list, like a Saturday afternoon, and I hear music in the background. He goes, oh, we're bumping his whole catalog in the resident room. We're having a great time. And I think these are the things that we can miss out on if we're so busy checking the boxes. What was their sodium? Did we prescribe their
Hmm.
insulin? Have we made sure to read the guidelines? These are important, but that's not the thickness of the story. The thickness is this man is a musician. He's so proud of his legacy of music. He's proud of it enough that we're now listening to his music in our workroom as we're getting the work done. That's part of what narrative is. That's what we want our trainees to learn about humanism in medicine.
And thank you for taking a step back to even explain it, because I think that the emphasis that you have on not necessarily actually putting those words down on paper, but everything that leads up to that point is equally important. The
Yeah.
observation, the moments in between, the not necessarily said out loud words or thoughts, but what you are able to collect from a patient that you know well enough. And I think that is really important. And how do you feel that narrative medicine has changed the way that you handle difficult conversations?
Oh, that's a great question. I think what narrative medicine teaches us, is to attend to the little details and the mundane moments so that when the bigger moments come, you know the human who is sitting across from you as best you can. In oncology, this is deeply important, right? This is how we broach goals of care conversations. This is how we talk about progressive disease. This is how we talk about the fact that toxicity of the treatment outweighs the potential benefits of the treatment at this time, but maybe forever. And, the way that you're able to do that meaningfully is to know your patients, to get to know them. And so this starts off in the very first visit. It starts off my first visit. It's the first 5 or 10 minutes. What is your preferred name? How far do you live from this clinic? Who are your people? Sometimes they'll come with their husband. Their husband is not their person. Their sister is their person, or their
Right.
best friend down the street is
Yeah.
their person. It's important for me to know who their people are.
Hmm.
What are your pets' names? What are your kids' names? Oh, you have 4 horses? Tell me the names of all of your horses. Why did you name them that? What do you like to do for fun? Oh, you really love to build string instruments, well, then if I'm picking cisplatin, I better be really careful about your neuropathy, right? Like this
Yeah.
isn't just what do you like to do for fun, but it's also how am I going to best treat you to help you maintain as much of your wholeness as a person. So you do that in the first 5 or 10 minutes. And trust me, it does not take that long. Like I tell colleagues this, and they're like, you're spending so much time. It's not that much time. I'm investing in the human being across from me, and I promise it pays dividends. Those patients, and then I tell them about me. And this is the important piece, Nirja, is that it's not a one-way street. For people to feel like it's a relationship, it has to be a relationship. So I can't be this nameless, faceless person who's just grilling them on their life. I then have to say, yeah, let me tell you about myself. I'm married. I have a dog I'm obsessed with. I like to ballroom dance, whatever it is I'm going to share with them. And then those patients feel like they know who I am as a person too, right? And then it's a relationship. It's you come with your history, your experience, and your disease process. I come with my history, my experience, and my knowledge, and hopefully together we're going to find a path forward. And so you do that at the first visit. And then every visit thereafter, after if it's a chemo recycling visit, I'm going to ask about your toxicities, of course. But if this is a check-in, if this is a, hey, how you doing? It's a scan review. Did you go on that cruise? Did your daughter have the baby yet? How's your dog doing? That puppy's not a puppy. I bet it's 100 pounds now, right? Show me pictures. And here's the secret sauce here. You got to mean it. Like
Yeah.
patients can smell if you're being authentic or not. For me, it's authentic. Like honestly, and you and I were talking about this before we started rolling on the podcast. Cancer is important. That's why they're coming to see me, but it's not that interesting. They didn't pick it. They didn't choose this part of their life. They chose to be an artist. They chose to be a parent. They chose to be a teacher or a volunteer or a
Mhm.
firefighter or whatever it is they're doing. They chose that. And I want to know that and I want to honor that. And so anyway, you invest and you lean into it. This is how you don't burn out in oncology is you lean into the people that you're caring for. I had a colleague, he's a retired now at Vanderbilt, just giant in his field, pulmonary critical care. And he said the most radical thing you could do is love your patients. Love them. And here's the thing, you don't gotta like them all, right? Just because somebody's got cancer doesn't mean they're necessarily a nice person or even a good person. But I don't necessarily need to like you to love and care and want the best for you. And when you lean into that relationship and you know that person, then when that hard conversation does come, and for many of my patients, it will come, they're not surprised, they're not betrayed. They know that I'm allied with them in what they want to have happen and what I would want to have happen. And they know I don't want to give them bad news any more than they want to receive it. It brings me no joy. And yet they know that I'm not here to give them false promises either. I'm here to walk with them, whatever that looks like. You can't do that and honor that human desire unless you know who your patients are. And this is not radical. My colleagues already do this in oncology. Like that's oncology for the most part does not draw people in who don't want to know their patients. It
Mhm.
selects for people who want to know people. So that's how you use humanism and narrative to know the human that you're taking care of, and it's not a manipulation tactic. It's just getting to know people. That's all.
I love having these conversations and I love the way that you take every single patient encounter to be, again, like you said, it's a two-way street. You have to share with the patient in order to fully understand them as people. And
Yeah,
that's important.
yeah,
And that's not something that we learn. That's not something that we may even be practicing every day in kind of the craziness and the busyness of our work.
yeah,
But
yeah.
taking those few steps and recognizing that the best way that you can take care of a patient is by fully understanding them. And the best way to fully understand them is for them to also understand you.
That's
That
right.
that is special.
And I
And
want to acknowledge, Nirja, just briefly, that it's
yeah,
hard to do this in residency.
yeah,
It's hard to do this in fellowship. It's hard to fully be present when you're still learning so much, and trainees are drinking from a fire hose every day. And
yeah.
so, if your listenership is a lot of residents and fellows, I want to acknowledge it is hard to do this. And what I just described is the privilege of being an attending for 5 years. Even in my first 2 years of attending hood, I was like, oh God, I'm not sure I'm picking the right chemo. I need to make sure I'm being safe, right? So there's still that distraction of, am I doing the right things? Do I know what I'm doing? And it's okay to sort of take a beat, even on a busy admitting service, even on a busy ICU shift, and say, tell me what you like to do for fun, or what does your family member love to do? I am sure if trainees are listening, and maybe you too will say, hey, that sounds great. I'm on hour 14 of a crushing shift. And we can't be perfect every day, and I'm certainly not perfect every day in this work. So I just wanted to acknowledge that out loud too.
I appreciate it. Absolutely. It gives us a lot of hope that there is light at the end of the tunnel.
Yeah,
And I think that itself is a big driver and motivation for how hard we work in residency and
yeah,
those in fellowship. So I do
uh,
appreciate that.
yeah.
One of the things I really appreciate about narrative medicine is that it gives language to something that so many people in medicine feel but don't always know how to articulate. And I think personally, this resonates with me as well, because part of the reason that I created this podcast was to practice reflecting more deeply and finding the words for experiences that otherwise can stay very internal. So I imagine that narrative medicine is not always the easiest thing to pursue in a field
No.
as demanding and fast-paced as oncology. But for our trainees and physicians who feel drawn to this type of work but don't necessarily know where to begin, what would you recommend to them?
Oh, that's easy. Your number one tool, you can buy it off Amazon. It's like $4, is a pocket notebook with
Hmm.
comes with a pen, pocket notebook and a pen. And whenever you have an interaction with a patient that makes you feel a certain kind of way, and it doesn't all have to be gloom and doom, it does not. Those feelings feel outsized, right? Those take up a lot of space in our brains when we're feeling um, really sad or mournful or guilty or shameful about a patient's outcome or what has happened. Those feelings take up a lot of space. But I find it is equally reflective to think about, damn, that patient made me laugh. Like I wasn't expecting to laugh in a room with a patient who's getting a new cancer diagnosis, and here I am laughing with them. That those feelings deserve acknowledgement too. And so here's the secret. You do not need to write the great American novel. You do not need to write 100 sentences a day. I tell people that a curse word is a full sentence, and sometimes that's all you've got for that day. Try writing down one sentence a day about something that you've experienced. And that could be where you stop. You do not need to do more than a sentence a day. And it could be reflective on anything with any patient. And it doesn't have to stop at patients either. Your colleagues are part of your journey too. You're allowed to write and reflect on any of those things. And the truth of it is, all of us, perfectionists, type A's, we're all stopped because we think that it has to be perfect out of the gate, or why would I write it down? If I'm not going to write the perfect piece of narrative, why would I write it? And
Yeah.
what I challenge my trainees in my program to do is, I'm going to give you 2 minutes to reflect on such a thing as life. That you get that prompt. I'm going to have you, you're going to get 2 minutes and you're going to reflect on um, laughing till you cry. You're gonna, you could pick any. There's so many writing prompts out there, but honestly, we see enough in our day to day. You don't need a prompt. Give yourself 1 minute at the end of the day to write one sentence on any interaction you had that day, and then put the book away. That's it.
Hmm.
That's a place to do that. And what I will say is, not everybody's a writer, but you don't have to be. We're all writers, actually. We sit down, we've written our fair share of H&Ps. We are all writers, whether we like it or not. And so this is just a different type of writing. For some people, they may not want to write. And for those people, I truly, genuinely recommend seeing if your program or programs in your area have debriefing sessions to talk about challenging patient cases. At Vanderbilt, we've actually built debriefing sessions into our fellowship that are run by our palliative care superstars. It's a safe space where our leadership is not a part of the conversation. That's where fellows can be totally frank and upfront about tough stuff they've seen or thought about. And then they're just given space to talk about it. What do we think that patient was going through that made them accuse me of not caring? And why have I been carrying that on my heart for the last 6 months? What does that say about how I think about myself as a physician, right? These are spaces where people can unpack, but if you don't want to do that in a group space, the number one place to do it is in a journal. And I swear there's something about writing on paper that's different than typing in your notes app on your phone. Get a little pocket journal. They're $3 on Amazon. Write every day one thing about one patient every day.
And key takeaway, it does not have to be perfect. It does not have to be
No,
something that is shared with the public or publishable or anything like
Correct.
that. That is a huge, huge
Yes.
point, and I think you are absolutely hitting the nail in which we as type A people expect that everything we do and everything we produce has to be perfect. So
Yes.
absolutely agree that this is something
Yes.
that needs to be as uncut, unfiltered, and spontaneous as possible.
Yeah.
So I want to now spend a couple moments talking about your narrative, Tamales, and you had
Mhm.
previously alluded to it. It is such a moving reflection on the human side of oncology, and it shows that our patients, they can leave a mark on us not only through their illness, but through their traditions, their identity, their culture. And I think it opens up a very important conversation about what really stays with physicians after the visit ends. So when we think about tamales and kind of it's centered on the idea that patients will invite us into their culture and their world. What do oncologists only learn about illness when they step in to their world rather than staying in the role of an expert?
Oh, that is a great question. There is really, I think, no end to what you can learn if you keep your heart open and your brain curious to what other people's lives are like. I jokingly, not jokingly say a lot of us go into medicine for the chisme, right? We go into it for the gossip. I want to know about who you are as a
Of
person. And
course, yes.
and I don't mean that in the way that I'm going to gossip about you, but I do mean it in the way that patients are going to invite us into the most intimate parts
Yeah.
of their lives. And whether that's centered around holiday traditions or relationships, I've had patients who have very dramatic relationships with the people in their lives, and they
Mhm.
invite us in. And in fact, they demand that we be a part of that, right? That is, there's no way to separate the three-dimensional part of the human from the disease. I cannot treat somebody for their cancer without knowing who they are, knowing whether it's safe, knowing whether it's going to be in line with their morals, with their ethics, with what's important to them. I have a very special patient. I carry her in my heart every day. She was wonderful. She was, I don't want to give too much detail away so as to not identify her, but she was diagnosed with a metastatic cancer. Her husband had been diagnosed with the same metastatic cancer many years earlier and had passed
Mhm.
from the disease.
Wow.
The treatments for them had not been very different in the intervening 10 years. And so she said to me, and she was a woman of very deep faith. And again, I don't want to share the specific faith, but a woman of very deep faith. And she said to me, I think I would like to forego all treatment and just focus on my quality of life. And this was over multiple visits, right? Multiple visits, that this sort of decision making happened where there were lots of medicines that I could have offered her to try to extend her life. And she just very, I think, gracefully said, this is not what's most important to me. What's most important to me is to minimize suffering and to avoid the side effects of chemo. I watched my husband go through, frankly, the very same treatments that I had received, that he had received. She's like, I don't think I want that for myself. And I'd rather just focus on what time I have left at home. And she lived for nearly a year with metastatic disease without a single chemotherapeutic agent. She was enrolled on hospice with probably 5 or 6 months before she passed. And, I visited with her every month until she was on hospice, checking in, making sure symptoms were well managed, helping to mitigate what I could. And, I think what I take away from that is she invited me into this very painful part of her history with her husband. She invited me into this very deep part of what drives her, which was her faith. I met both of her sisters who were her caregivers and got to know them incredibly well. I think patients invite you, and her faith tradition was not my own. What had happened to her husband was a very personal and private thing, and yet she brought me into that fold so comfortably and willingly. Because it made a difference in how we took care of her. And again, I don't think this is special about me. I think the vast majority of oncologists do this at baseline. We have to. But I think patients trust us with their traditions. They trust us with their culture. They trust us with what is important to them. But you have to ask. You have to show curiosity.
Absolutely. And I think you very well describe what cultural humility really looks like in an oncology visit. It's not necessarily shouldn't just be a slogan, but it's actually the words you choose, the questions you ask, the assumptions that you refuse to make. And like you said, it sounds like a skill that you refine over time. And asking those particular questions to better treat or heal the patient that is sitting in front of you. And as we start to wrap up, one of the questions that I like to ask all of my interviewees on this podcast is if you had one piece of advice that you could share with any trainee who is interested in pursuing hemonc, what would that be?
Ooh. Just one piece of advice. I think it is to find one human element in every interaction you have with a patient. This is what I challenge my residents to do
Yeah.
when we're on the inpatient service. Maybe patients are admitted for pain crisis, or they're admitted for progressive disease, or they're admitted for hyponatremia, or whatever it is. Every day I say at the end of rounds, we're going to talk about one human element that we noticed on rounds. It's not everything. It's not building a longitudinal long-term relationship with patients. But when I think about the things that burn us out in medicine, and oncologists are not immune to it, I think it's feeling detached and dissociated from the work that we do. It's feeling like that you're just checking boxes. You have to very intentionally not do that to remain connected to your work, and especially for trainees where we ask so much of you. We ask you to be everywhere and learn everything and do it on less sleep and less pay and crappy overnight hospital food. We ask you to do all of that. So, whatever part of oncology you're going into, really find one human thing about every patient you take care of to remind you why you're in this work. That would be my advice.
I love it. That's excellent advice. Thank you.
You're welcome.
Dr. Dupuis, I am really grateful for this conversation, and I think that you've put words to something that really sits at the heart of oncology, that even in a field very defined by hard conversations, high stakes, there is still so much room for that connection, that meaning, and that humanity. So thank you for bringing that, and thank you for sharing that with your trainees, including residents, fellows. This is what makes me very excited about this field, despite how, as we talked about, difficult and emotionally challenging and burned stomach can feel. I think that there is just an untapped amount of humanity that we can really lean into if we open ourselves up to it.
I completely agree. I couldn't have said it better.
Thank you. It was a pleasure to have you on this podcast, and I am so excited to share this with the world.
Thank you so much for having me, Nirja. This is such an amazing podcast and an amazing body of work, and I'm just grateful to be a part of it. Thanks for having me.
Thank you.